are seated, I can start with the first question for Øystein. And in this case, perhaps I'll have to switch between Swedish and English. The question is, min ena fråga gäller Rituximab-studien, fas 3, där man inte såg signifikant skillnad. Den grupp som inte fick Rituximab fick saltlösning. Jag undrar om man reflekterar över detta att man ger två olika behandlingar, two different treatments. The one that did not get Rituximab had a saline solution. Är det då inte en dubbelblind studie? Jag ser också att vissa personer som blivit bra med Rituximab hållit på längre tid och haft högre doser än det som gavs. Finns det chans till studier framöver med Rituximab och intravenöst immunglobulin i kombination? Och där man inte ger saltlösning till kontrollgruppen. If there are chances in the future for Rituximab and intravenous immunoglobulin in combination. Did you get the question, Øystein? Hörde du frågan?
I think so. It's no doubt that the randomized phase 3 study was negative. There were no significant differences between the Rituximab and placebo group. And in the placebo group, it was a double-blind study. And we had small amounts of albumin added to the saline for the placebo group so that the solutions were identical when you looked at them. So the patient could, or the nurse giving the infusion could not guess which one. So I think it's a double-blind study. In the Rituximab maintenance study, with higher maintenance doses of Rituximab and longer period of maintenance, there was no placebo group, and it's therefore difficult to know exactly how we should interpret the results. But to the best of our clinical judgment, I think it's fair to say that we believe that there are patients that respond to Rituximab, but they are too few using Canadian criteria and how we selected patients. They are too few to get a significant difference. Maybe also it could be an issue that the doses in the maintenance phase were lower, but I would expect to see some differences in the randomized study. So I think it's fair to say that it's a negative study. That doesn't mean that nobody can have effect from Rituximab. We are not pursuing with the anti-CD20 antibody, but as I told you in the presentation, we have doing a small pilot on plasma cell targeting, because we think that there are several reasons for the negative study. It could be the patient heterogeneity, it could be placebo mechanisms, a natural variation of symptoms, but also it could be, like in many classic established autoimmune diseases, that you have autoantibody production from the mature plasma cells that you do not touch with Rituximab. So, but we are in the early stage and only doing small pilot experiments and a small study, so we cannot say anything more about that at the moment. I don't know if I answered the complete question because there were many, but I don't think this, if the question was meant to be that if saline could affect the symptom picture, the symptoms of the patient, I don't think so, because it's only half a liter of saline, and it's given 3 months apart. And if they had some impact on the symptoms, it would be during the first days and not for 2 years. That's my answer. If was there any other things that you mentioned that I didn't touch?
I think that was an extensive answer. So I think we'll go on with the next question. Thank you, Øystein. And this is a question for Carl-Johan. Are there any dietary recommendations when it comes to ME patients regarding their difficulties to pick up energy, so to say?
Okay. Thanks. Okay, yeah. So no, there are no general recommendations regarding diet, and I think so. In the metabolomic studies, we have been able to touch some aspects of that diet because we measure metabolites from different types of diet, and we have tried to answer questions related to that. One thing that often comes up, if it might help with some kind of reducing the sugar intake or trying even ketone diet, and this is something that has not been tested properly. So we do not have any science-based recommendations to tell about.
Thank you. I just want to say that we will try to end this at like 5:20 or so. But we want to have some questions and comments from the audience, of course. Yeah? Next one. From the audience here. Please.
Thank you. Sharam Lavasani, Lund University. I was wondering regarding the Rituximab study. Do you think that the individuals, responders versus non-responders, could represent different categories or subgroups of ME-CFS patients? Perhaps depending on the level of the O2 antibodies, or I don't know, there are also studies showing the impact of the gut microbiome on immunotherapies in cancer using antibodies. So do you think that that could be the case, or have you seen any gender dependency regarding the responders, non-responders?
Yes, I think it's a good question, and I think we have learned a lot during the last 10 years, also after these clinical trials. And one thing is that that I was talking a little bit on, but didn't comment further, is what is the normal variation of symptoms? And now we have done a study with no intervention, only observing patients with regular questionnaires and Fitbit armbands, measuring resting heart rate and steps per 24 hours and so on. And what we see is that we can see that the natural variation of symptoms is higher in patients with milder degree of ME-CFS, at least in our study with only 27 patients observed closely. And I think that when we look at the SF36 data that Professor Rowe also talked about, we can see that in the milder group of patients, and I don't mean that mild ME-CFS not is bothersome, but in the mild group, we can see that there's almost 20 SF36 point variation throughout these 6 months for SF36 physical function. While for the moderate and moderate to severe patients, it's very stable, only varying 3 points. So I think that we did this because we wanted to learn a little bit more and be able to design better outcome measures, and also to see which patient, how can we make the difference between true effects from an intervention and natural variation of symptoms. And that will be crucial if we are going to be able to, if we have an intervention that works, it's important that we cannot forget about the placebo mechanisms, because they will also be there, but the natural variation, we can have some idea. And when we are doing this small pilot study, we have a 3 months run-in with only observing and doing continuous registration at the Fitbit armband and questionnaires quite often to try to capture what is this patient's level of variation, and then start intervention so that we can have some idea on try to minimize the difficulties in detecting the true effects. So I think also in the Rituximab study, we also see that the variation and most of the responders in the placebo group were in the milder categories of the disease. And we have now done a follow-up study 5 to 6 years after, just analyzing, and we will try to publish that because there are some interesting data emerging, but we cannot make any firm conclusions because after the study, the patients were told which kind of intervention they had. But the next 4 years is also some interesting observation. We're doing the same now with the cyclophosphamide study. We're doing a new follow-up study 6 years after the first one, trying to also get some idea on what is the natural cause of the disease.
Thank you.
So,
Thank you, Øystein. Another question? Yes.
Hi, Cecilia Tabella. I'm a doctor here from Stockholm. And my question is actually, I think, focused more to Carl Johan. And it's looking at the mitochondrial hypothesis and maybe a dysfunction. There's research coming now with transcriptomics, as in looking into the gene expression. And from my point of view, I do believe that ME is a name of various conditions. And as long as we don't pinpoint exactly what's wrong, it will be hard to find a cure. But there's some interesting research on transcriptomics and then the possibility to maybe actually map the disease from a genetic expression point of view, and without also peptide treatments. And I'm just wondering what your take on that is.
Yeah, so first, I think some of the elements can be, in theory, explained by mitochondrial dysfunction, but the clinical picture doesn't match a genetic mitochondrial disorder. That's something completely different. So we don't think there is a kind of destruction of the mitochondria in some way, right? No, but that the mitochondria and also the metabolism in general is highly regulated, and also you can pick that up with transcriptomics data, which is gene expression data, and you can see aspects. I think if there is an underlying mechanism that is important, probably that should be, of course, visible in your restricted patient cohort. I think. So what we have done with this study, and based on the clinical studies here, is that we try to classify the patients as strictly as possible, to try exactly because of what you say, that if they have a common mechanism, they should be similar, or the other way around. They are in a group with patients that are similar. We are more likely to pick up a common biological mechanism. But still, I agree that there might be different mechanistic elements also inside the group of our patients. And we have seen that with the metabolomic study, with the different patterns of adaptation. And the adaptations themselves may also influence the symptoms and symptom severity. So it's quite complex to try to figure out what is the underlying cause there and the triggering mechanism compared to what happens downstream. And I think, to address your question more directly, I think that is a complexity that will also be apparent if you're doing broad-scale transcriptomics, and also depending on the tissue or cell types you're choosing and things like that.
So I want to clarify, I'm not looking at thinking it is a mitochondrial genetic disease. I think maybe that the mitochondria, we have genes in our mitochondria, it has its own DNA, and it actually regulates some of the responses in the cell. So looking at the possibility on looking on what's on and what's off, so to say, of course you might have your susceptibility because of whatever SNPs you carry, but we're all sitting in this room and listening to this. So obviously we're working good enough to be here. But looking at that aspect, because from my point of view, seeing quite a few patients, they are very different, and the treatment then needs to be very individualized, and which I think is probably the reason why the Rituximab study then becomes negative, because as long as we can't identify that certain group, to pinpoint them, we will not be able to pinpoint what treatment that exact patient needs.
Thank you. I think I just want to hear anyone else having a brief comment on that. Anyone online? No? Okay, so then I think that we will go on with a couple of questions from the screen here, from the that have been sent to us. I have a couple of questions for Peter Rowe. One is, and I think I'll read a couple of them right away. Do you believe the orthostatic reactions contribute to a wish of the patients to remain in bed? And could it be a physiological defense mechanism that the patient is not yet ready to stand up? And the other one is, do ME patients have a more extensive risk of getting early heart failure compared to non-ME patients? Did you get the questions, Peter?
Yeah. I'll answer the second one. We're not aware of any early heart failure results from long-term studies. And in the 20 or actually 30 years that I've been treating people with this illness, I have not seen anyone develop congestive heart failure. The orthostatic intolerance issue, it likely contributes to some people being bedbound because they feel so uncomfortable, sometimes even just sitting up. And so the orthostatic intolerance can be a big factor that contributes to the disability. We find that if we can get that under better control with various medications, people's function improves and they tend to expand their activities more once their circulation is better managed. And they actually don't need any goading or encouragement from us to expand their activities. What is interesting with regard to outcome measures, as Austin was talking about, is that often fatigue is the last thing to disappear, that people will, in a very healthy manner, expand their activities so that they can participate more in life while tolerating a bit of fatigue. And we find that fatigue is the last thing to improve.
Thank you, Peter. Do we have another question here in the audience?
I would like to thank all the speakers once again. Just focusing on exciting data on the metabolic shift that Carl-Johan presented, and also the joint hypermobility that you have presented, Peter, and you mentioned that this might be due to the overactivation of histamine. And due to the fact that these might also have an impact, both of these factors, from the gut microbiome, do you think that it should be wise to extend these areas to the gut, perhaps, and digging into that as a source of these complications, since recent studies are really showing the direct association between the dysbiosis of the gut microbiome and ME-CFS? So perhaps the disruption has also something to do with the disruption of the digestion, which is also known in ME-CFS, and absorption of different nutrients, which in turn can have actually an impact on this shift of metabolic parameters that you presented, or overactivation of mast cells and histamine production.
I'm not sure what's that a question for.
Yeah.
The question is, should we extend these fields to the microbiome?
Someone's calling to your computer here, Kerstin.
What do you think, Peter?
You know, there have been some studies of the microbiome. I think, you know, as I've watched that field unfold over the last 20 years, certainly there's a lot of complexity. The microbiome must be involved to some extent, but I think I've yet to see data that are convincing, suggesting it's a major factor. And perhaps I misunderstand the work. We've found, as many others have, that if we pay careful attention to our patients who have a lot of facial flushing or hives, rashes, itching, that the more we pay attention to these symptoms of mast cell activation, the more we are identifying. And the good thing about looking at mast cells is that many of the treatments are quite benign and well tolerated by patients. So that if you can identify somebody as having mast cell activation, often there are some very readily available, even over-the-counter treatments that can change the quality of their life. So I'm with you in expanding the research into all of those areas, especially the mast cells.
Thank you. Anyone else? Brief comment?
I think we might get an answer to that. There is an ongoing fecal transplantation study going on in northern Norway. Maybe that can tell something. And also there are big omics studies going on internationally. So I think it's an important aspect to study. But yeah, that's all I can say.
Okay, so I think that I will direct 2 questions for perhaps the entire panel, more or less. But to start with, Brian, the updated NICE study or results, so to say. What's your feeling? Do we get out with the new message, the updated message, or how can we promote that in a way?
Yes, I mean, there's been a degree of a kind of coordinated backlash almost. There's been a flurry of small review papers appearing and little blog posts and things like that saying that, and the Royal Colleges issued a joint statement to the effect that we think the guidelines are important and we're delighted that they came out. We also think that weighted exercise therapy should continue and that cognitive behavior therapy works. So this was anonymously posted on the Royal College of Physicians website on behalf of several Royal Colleges. I think we have to kind of expect a certain amount of that and be aware of it. But I think professionals and serious people are, capable of making their own minds up to an extent. But I do think we need to proceed, follow the evidence-based guidelines, promote awareness of them, but be aware that there is a sort of a counter-protest. And this is just like the philosophers of science would have predicted about the scientific revolution. There will always be a counter-protest for a while, but that will dissipate. So it's not all perfection and everybody changing their minds at once, as I've mentioned. What we can do is continue to be ambassadors, be vigilant ambassadors on behalf of the new guidelines and the new regulations. And I would add, stand up to people who engage in toxic behavior, and that's advice for life in general, I suppose. But there's something toxic about just simply contradicting things and saying these things are evidence-based when they no longer can reasonably be said to be. There are enough professionals in the room to be able to do that. It's often more difficult, I would say, for patients to do that, and especially with ME-CFS, because part of the gaslighting here is to tell the world that these patients are their own worst enemies and they're actually bullies. And so any patient who criticizes a doctor can immediately be cast as a villain. So it's important that as professionals and as academics that we take a stand on behalf of the community and on behalf of the science.
Thank you, Brian. Hear, hear. So with the role of being moderator comes some power. So now I will read the last question, I promise. And this is perhaps directed or addressed to almost all of you, but perhaps more specifically a little bit to the patient associations. And this says, how can we jointly work and promote this kind of research ahead? Are there joint projects on an international level to get some lessons learned from? Do you have any take-home messages from the patient societies to start with?
It's a difficult question, and if I knew the correct answer, things would look very different right now. I think we just have to keep on working, as Brian said. I think we have to use a trickle-up theory. It's very good to arm the patients with knowledge that they can bring to their doctors. In Norway, we have a project about teaching teachers how to teach students with ME and what they can do to help them. And we're finding that it's a very pragmatic approach, and we're finding that that is just what makes it so effective, because we're not talking about the cause of ME, but we're talking about this is what you can do to help. And many teachers are very happy to get that information. And I think very many doctors are also uncomfortable with ME because they don't know what to do, and we can help our GPs and our family doctors to help us. And we just have to keep on talking to the politicians and to the health authorities, and yeah. One day, things will change.
That's a good take-home message. Kerstin, do you have anything to add to that?
Well, yes, I'll just add that before the end of this year, the school project, the toolbox, will be finished in Sweden as well. So we can offer teachers the education. And then I would like to stress that we cooperate in the Nordic countries. We cooperate within the European countries for advocacy and support and knowledge spreading. I can't find the English word. So dissemination, thank you.